The next speaker is Hal Gerstein, who's going to talk about poorly differentiated lesions, which is a total different kettle of fish than what we've been talking about most of the day, the undifferentiated nets and our approach to these things. Thank you very much for Hal.
Hi, everyone. I'm the last speaker for the day, yay, and we're going to bolt the doors so you can't leave early. So let's see how this works. I've been tasked to speak about poorly differentiated and undifferentiated neuroendocrine tumors. What makes me so qualified for this? You've heard today from some of the from the country's real experts in neuroendocrine tumors. I am a practicing medical oncologist on Long Island in the suburbs in a small private practice, trained in conventional oncology. I think that makes me perfect to talk about this for you. Okay, so first, disclaimer, I don't work for anybody but my patients, and I don't answer to anybody but my wife. I also answer to Mary Ann Wayman, who actually got me into this field. Yes, Mary Ann's been great. We should all answer to her. Mary Ann got me into this field over 2 decades ago when she was first diagnosed, and she asked me to be her local oncologist. Nobody really knew that much about this disease 20, 25 years ago, and I had known her for an unrelated condition, and she asked me to be the liaison. And, you know, I've been honored to be mentored by some of the experts you've heard today, Richard Warner and Odo, and Eric's been my friend for the last couple of years, so I really rely on these experts, as you should too, to get some of the newest information. Well, this is a typical neuroendocrine cancer cell. Notice this is a differentiated cell. Why differentiated? Because it has receptors, it's making proteins, it has targets for us to attack. That's what you've been hearing about all day today. Forget it. We're not going to talk about this. So forget that slide. Because this has been going on all day and you probably forgot everything that's been going on since the morning, a quick overview. Neuroendocrine tumors, otherwise known as carcinoid tumors, can occur all over the body. They're characterized by the ability to produce peptides and cause symptoms. Again, forget it. We're not going to talk about that. We've also mentioned today that the incidence is rising faster than other malignancies. This is the rise of neuroendocrine tumors, and other malignancies have risen a little bit, but not that much. Why? I don't know. Is it because we're detecting more, we're being made more aware of this by our good friends here? Perhaps. And the neuroendocrine tumors are increasing across the board on the sites, but what's very interesting is lung nets are increasing faster than anything else, and we will talk about that. Okay. It's not confined to the United States. This is a global phenomenon, okay, and it occurs across races as well. Incidence of malignant neuroendocrine tumors are increasing by stage as well, and of course, we're recognizing neuroendocrine tumors faster, so we're diagnosing the localized tumors, and that's good, because we want to be able to attack these localized tumors by what? By surgery, of course. Okay. But NETs are very often diagnosed at the advanced stages, okay? Only 50% of all NETs are diagnosed as localized tumors. Most of them are diagnosed as either regional spread or metastatic disease. Okay. Why is that? Because we don't see the symptoms until after they become metastatic. The symptoms, flushing, diarrhea, that occurs after the metastases for the most part. Okay. Now to the crux of the issue. Okay. We heard from our pathologist this morning about poorly differentiated neuroendocrine carcinoma. Okay. They behave as a highly malignant cell. They metastasize very early. They have very high proliferative rate, your Ki-67, which has been discussed ad nauseum already. And they infiltrate. They can be of any size. They can start in microscopically and metastasize all over the body, okay? The prognosis in general for untreated patients is poor. We're going to fix that if we can, okay? So, of course, survival is associated with stage, okay? Patients with localized tumors are better. Survival is about 33 months. Patients with high-grade tumor are poorly and undifferentiated tumors. The median survival of untreated patients, a lot less, okay? So, to review, take-home points, okay? The function of nets of differentiated cells is they produce peptides. Not all do. Poorly differentiated nets in general do not produce peptides, in general do not have those receptors that we can target. Occasionally you'll find a poorly differentiated patient that is positive for SSA receptor and you can use sandostatin. But in general, these targets are absent in the poorly differentiated and undifferentiated tumors. The median survival is not good because even small tumors become metastatic. The tumor grade makes that happen, and we don't like that. Okay. So, accurate histology, very, very important. Okay. The accurate histology determines the overall prognosis and probability of response. It's also the degree of differentiation is characterized by the proliferation rate. The higher the Ki-67, the more proliferative it is and the more poorly differentiated or anaplastic tumors these are, and they behave very, very aggressively with rapid growth rate and early dissemination. However, and this is the take-home for this, the cells that grow rapidly dividing cells, have the potential of being more sensitive to aggressive chemotherapy, okay? And we'll talk about why. Chemotherapy is a selective treatment. We have to select our patients carefully with nets for which patients we're going to treat with chemotherapy. Not all patients respond equally. So again, we have to maximize response. To understand that, we have to go back to basic biology and the cell cycle, okay? When the cell is actively growing or dividing, it's in the active part of the cell cycle. When a cell is outside of the cell cycle, it's in G0 or resting, okay? Those cells in G0 are not sensitive to chemotherapy. Now, our typical neuroendocrine patients, slow growing, we've talked about that ad nauseum. We've told patients, oh yeah, you have a neuroendocrine carcinoma, it's slow growing, okay? Those cells in that tumor are mostly going to be in the G0 phase. In aggressive cancers, there you have a majority of the cells in the active cell cycle. And when the majority of cells are in the active cell cycle, they're going to be more sensitive to agents that attack cells that are growing rapidly, okay? Now, normally, cells have a function of programmed cell death. It's called apoptosis. It means that when we are growing, our cells will reach a certain limit and stop growing, okay? That's normal, okay? But when cells grow out of control, there's a loss of apoptosis, okay? And that's what a cancer is, okay? The most potent cytotoxic agents are active in the active part of the cell cycle, not in G0, okay? The more cells of a specific tumor, so if you have a specific tumor and the fraction of cells in the active part of the cell cycle is increased, that means more cells in the tumor will be sensitive to aggressive chemotherapy. Okay. What is cancer chemotherapy? Okay. Cancer chemotherapy kills cells that are actively growing, okay? So we want to know what the growth fraction is, how many cells at a particular point in time are growing or actively growing, okay? Oops, I'll go back. Okay. A tissue with a large percentage of proliferating cells have a high growth fraction. Tissue that has a low percentage of growing cells, more cells in the G0 phase, have a low growth fraction. Okay. Chemo works in various ways depending on the agent we choose. Certain chemotherapy drugs can damage the DNA, certain can inhibit the synthesis of new DNA, and certain drugs stop the mitotic process of the cell, and even more can stop the metabolism of the cell. Okay. So this is just a schematic that shows in the active growth cycle, active part of the cell cycle, where different chemotherapy agents can or have the potential of working. So simplistically speaking, again, if there's rapid tumor cell growth, like in a poorly differentiated or undifferentiated tumor, then there's a larger number of cells in the susceptible part of the cell cycle, that part of the cell cycle which is not G0, and therefore, at any given time, those cells will be more sensitive to chemotherapy. Why doesn't it work all the time? I mean, this sounds so easy. Give chemo, and aggressive tumors should go away. Okay? The reason it doesn't work all the time is because cell kinetics is not what we call linear. It's not a straight line. Cell kinetics, cell growth occurs according to a concept called GOMPERTZIAN growth. It's a GOMPERTZIAN curve, which means that in the beginning of a tumor's life, when tumor starts growing, tumor cell growth is slow. At the end of a tumor lifespan, it's also growing slow. Tumors grow more rapidly in this phase, in the middle. See how the curve is going straight up. It's a rapid proliferation, okay? The problem is that many times we don't detect cancer until it's already reached a larger size and is slower tumor growth. So it makes sense that chemo would probably work better here, but we don't detect the cancer in time. Okay, well, let's skip this slide. Okay, so again, this is just pointing out that more rapid growth, more susceptibility takes place here on this rather impressive upward swing. Okay, so I kind of took offense to the whole concept of this cancer moonshot, which is this political speak to accelerate our attack on cancer, and that's because attacking cancer is not a moonshot, it's a war. And you know, our guys in DC, and this is the last thing I'm going to say about politics, but our guys in DC don't like to use the word war. But we're in a war against cancer, and a war is fought and won in the trenches, okay? So I like to quote General Patton, who's one of my favorite guys to quote. And to win a war, you have to know history. He was a great historian, okay? So let's go back and talk about how chemo was founded. Chemo was initially started, about 70 years ago now. And Paul Ehrlich is considered the father of chemotherapy. He won a Nobel Prize, and he came up with this concept of the magic bullet, which we don't really have yet, but I think we're approaching. So we'll talk a little bit about that also. Nitrogen mustards were the first products that were found to be effective against growths. They found that in World War II, there was an explosion and certain servicemen were exposed to mustard gas, and they found that their lymphoid tissue shrunk. Nitrogen mustard then became a mainstay of chemotherapy against lymphomas. Okay? Lymphomas, as you know, can be very rapidly aggressing tumors. Okay. In the 50s, folic acid was found to accelerate the progression of leukemias, so antifolates became a mainstay of the use against childhood leukemias. Again, very, very aggressive cancers, and yet certain chemo agents were working very well. In the 60s, combination chemotherapy began to be used against leukemias and lymphomas, and guess what? We were able to induce remissions, a very high percentage of remissions in these formerly fatal diseases. So now systemic chemotherapy is the mainstay for a lot of disseminated malignant diseases. Many are cured, and chemotherapy should not really be shied away from in certain instances. How do we use chemo? We use chemo as primary treatment, so it would be the sole anti-cancer treatment for certain tumor cell types like leukemias, lymphomas. It can be used as adjuvant therapy. Adjuvant therapy means surgery is your primary therapy. Let's say in a breast cancer patient. Breast cancer patients have a mastectomy, and many patients have to have chemotherapy after the surgery. That's kind of to mop up microscopic residual disease that might be left behind. Okay? And then there's neoadjuvant therapy. Sometimes the tumors are too big to undergo successful surgery, so we give neoadjuvant therapy, shrink the tumor, then we can go back to primary therapy, which would be the surgery. Okay. Where does that fit in to this Gompertzian equation that I talked about before? And this is really very simple, okay? If you have a large tumor here, okay, and it's growing slowly, okay, it's a fraction here that's slow tumor growth, neoadjuvant therapy might be able to shrink it up and prepare the patient for surgery. Primary chemo can be used for highly sensitive tumors like your lymphomas, and after you can give adjuvant therapy to mop up the disease. That's our conventional process for chemotherapy. There's a wide variation for sensitivity of chemotherapy, and look what we got here. In the highly sensitive tumors for chemotherapy, we have lymphoma, leukemia, testicular cancer, which is curable by chemotherapy as well, and small cell lung cancer. What did our pathologists tell us about small cell lung cancer? It's a variant of poorly differentiated or anaplastic neuroendocrine cancer, okay? So just I'm going to touch on this and mention it. The Goldie-Coldman hypothesis basically says the best chance of cure when you're treating a patient with chemotherapy would be to use effective, many different agents that are non-cross resistant at the same time, and you've got a better chance for curing. We have to attack the tumor like a war, like a battle, on different fronts. So we're using two non-cross resistant agents, two or more, and we might use them at the same time, or we might use them sequentially, but it's two different fronts. So to summarize briefly, the magic bullet isn't out there. Maybe it's coming. I'm not sure yet. We'll talk about that towards the end. Conventional chemotherapy targets have been the cell cycle, microtubules, and DNA for rapidly growing tumors. Combination chemo improves response, and it's better to treat micrometastatic disease than bulky metastatic disease. So we still rely on our surgeons to cytoreduce, to reduce the load of the chemo, and sometimes we use other agents to reduce the load. Okay. For classical chemo to be effective, cell proliferation is required. Indolent tumors, slowly growing tumors, are more resistant to chemo. Rapidly growing tumors, more sensitive to chemo. Okay. And we then have to finally deal with the concept of tumor resistance, cell resistance to chemotherapy, and how we're going to overcome that. Okay. So, it's not. Okay. So, the mainstay of chemotherapy for our poorly differentiated or anaplastic tumors has been a platinum analog, a combination of cisplatin or carboplatin and another drug. Classically, it's been etoposide, but it can be other drugs, and we may want to alternate with other agents as well. I'm not going to go into that because that's something that's individually decided with each patient and their oncologist. We're really here to talk about concepts. This is a great slide, but I can't even talk about this without having a couple of bourbons first. Okay. Okay, we talked about the rationale for chemotherapy. Routes of administration, chemo can be given orally, intravenously, uncommonly intramuscularly, can be given into the CSF, into the spinal fluid, can be given intraperitoneal, okay? Intrapleural, which is in between the lining, the lung and the lining of the lung. We can do isolated organ perfusion. You've heard about that today as well. It can be given intrapericardial and into the liver. Oh, God, I'm not very good at this. Okay. How do we plan chemo? Chemo is dosed on body surface area in general. It's different in adults and children, of course, adjusted for the elderly, for those who have poor nutritional status, who have on concomitant medications or have comorbidities or other illnesses that we have to consider, who have low blood counts, who have received radiation therapy or liver-directed radiation therapy that we talked about. And chemo is given on a schedule. For those of you who are familiar with chemo, your oncologist plans a schedule for you. Why? Because chemo has its tolls. It has side effects, and the body has to recover from the side effects. We have to recover from suppression of our cell counts. We have to recover from the nausea. We have to recover from the weakness, okay? And sometimes that takes a week, sometimes that takes 2 or 3 weeks. So we have intervals, we have these schedules. The number of cycles that we give to a patient depends on the stage and the side effects. I like to keep our treatment intervals as short as possible. During the recovery phase from each cycle of chemo, there is a chance that we may have some growth of tumor. So we don't want to take 2 steps forward and 2 steps back. You know, 2 steps forward and a half a step back is acceptable. And then we plod on with our chemo. We have to give time for the bone marrow to recover. It takes a white blood cell generally 8 to 10 days to recover. The lowest part occurs about 14 to 18 days after a maximal dose of chemo. So we need that time. The recovery time in general is about 21 to 28 days in a chemo-naive patient. So our schedules are usually every 3 to 4 weeks. So what's my approach to aggressive, poorly differentiated neuroendocrine cancers? I think it's best summarized by this very classic movie, which was called Space Jam. And Space Jam was, as you know, probably know, it's a movie with Michael Jordan and the inimitable Bugs Bunny. And the theme song goes, if you hit 'em high and hit 'em low, in the game we take you to war. And that's basically what it says. So we have to hit them from at least 2 different fronts, and we'll be able to win this war. So when we plan chemo, we're looking for increased activity, the best active drugs we can have to our patients, the highest doses we can safely give, and we look at safety. Okay, we have to have our side effects that are manageable for our patients. Okay. Is that all we got? Is that all this is all about? You know, chemotherapy for these patients? And the answer is, again, Patton said, if everyone's thinking alike, then somebody isn't thinking. So we've got to move on from chemotherapy because it's not the answer. And the puzzle of cancer therapy has now got 4 pieces to this puzzle. It used to be surgery, then it was surgery and radiation, then it was surgery, radiation, and chemo. Now we add in immunotherapy. And I know Dr. Wolin touched upon this, but we're going to talk about it again. In a classic differentiated cell, we have many different targets to attack. Now we are going to use something called the T cell. We all have T cells. We want to activate our T cells, we want to turn them into killing machines, and we want these killing machines to attack our cancers. The concept of immuno-oncology is the cancer cell produces antigens. Antigens are substances that might be on the surface of the cell and they're released into the bloodstream. Okay? We would call an antigen a foreign body if it wasn't from our own tumor cell. An antigen might be a bacteria that we pick up. A bacteria is recognized by our immune system as a foreign body, and we develop antibodies to it. Okay? The problem is antigens from tumor cells are our own substances. The immune system has trouble recognizing the difference. The antigens are picked up by these APCs, antigen-presenting cells. We used to call them dendritic cells because they look like they have these little dendrites. But they're actually picking up these antigens, and they're presenting these antigens to the T cells. They activate the T cells, and the T cells, these activated killer T cells, now come back to the cancer cells and kill them. That's a great concept. Doesn't quite work like that. The problem is we have these checkpoint inhibitors that checkpoints that Dr. Wolin mentioned that stop this process from happening. Okay. So the first checkpoint, CDCL up here, stops the cells from being recruited. We have an agent that now helps recruit the killer T cells. The second checkpoint is the PDL checkpoint down here that Dr. Wolin talked about also, that essentially inactivates the T cells. So now we want to increase the recruitment and we want to keep them active, okay? And that's what immuno-oncology is all about. Okay. Immuno-oncology has been used as single agents, but they can also be used as part of a treatment program. Which part of the treatment program do I see it working? Well, we come back to this Gompertzian growth curve, okay, and we look over here where there's slower tumor growth. So now we saw the tumors grow. Now we want to bring the tumors back down. We want to reverse this curve. So in slow-growing tumors, this is where immuno-oncology agents might work very well. In the rapid phase, where rapid cell growth is, it's more susceptible to chemo. And again, when we bring the tumor cell count down, again, we can use immuno-oncology. So this is where I see it integrating into our plan for cancer treatment. People with cancer are living longer. Look at us here. We know that, okay? We also have to focus on the quality of life in addition to the quantity. We want our patients to live normal lives. We want new treatments. We want treatments with less toxicity, and we want to mop up these small tumors that we were able to attain. We can take large tumors and cytoreduce them with surgery, with liver-directed therapy, sometimes with chemotherapy. We can bring these large tumors down to microscopic levels. Let's not allow them to grow back. Let's not allow them to become resistant. And this is where our immuno-oncology comes to play. And finally, my last thought to you guys is that if you're going to win any battle, you have to let the mind run the body. Mind over body. Never let the body tell the mind what to do. Your body is not as strong as your mind. Don't let your body give up, okay? And then that's a good part of the battle. Help us help you. Thank you.